Welcome, everybody. My name is Dr. Dennis Goodman, and I'm a clinical professor in the Department of Cardiology and Preventative Medicine at NYU Langone and Director of Integrative Medicine at NYU. It's my great pleasure today to welcome our guest expert speaker. I'll tell you a little about Dr. Newman shortly, but in the meantime, like I always do, I'd like to give you a little background on how the lecture series started, what we've been doing, and what's coming down the pike. Next slide. Next slide. So right off the bat, I know that many of you have questions. You like to ask questions. We've all become familiar with this format now. If you have a question, you can type it into the Q&A box. I'll be fielding the questions even while Dr. Newman's speaking, and we'll get to as many questions as possible. Try to keep it brief with a specific question. Next slide. I think we've got to go back one. So this is what's coming up in the next few months. And you can see we've put the dates and the times down. We're going to have in December tips to avoid anxiety and depression over the holidays, congestive heart failure in January, and Women's Health Update in February, which is Women's Heart Health Month. Next slide. I'm proud of the fact that we've had over 40 lectures, close to 50 now, since 2015. You can see some of the topics that we've had. And if you look carefully on the second column, we did talk about diabetes 2 or 3 years ago. And I'm delighted that we can get Dr. Newman back to give us an update. Next slide. So we have a lecture library. We've worked hard, and you can actually access many of our lectures, our previous lectures, on YouTube. And we've actually had some some great success with this, with sometimes up to 15 to 20,000 people listening to these lectures from around the country, which is really rewarding. Next slide. So keep in touch with us. There are many ways to keep in touch with us. There's the website, email, and Twitter. On the next slide, I've put down the only email real address that you need to know. Website address, nyulangone.org/heart health lectures. And from there, you can access YouTube, you can find out what's coming, and you can email us, and we can put you on our list of contacts. Next slide. So now it gives me great pleasure to welcome our speaker today, Dr. Jonathan Newman. He is the Eugene Brownwald Assistant Professor of Cardiology in the Department of Medicine, and he's board certified in internal medicine and cardiology. He received a Master of Public Health and Medical degree from Northwestern University. Dr. Newman completed his internal medicine residency as well as his cardiology training at Columbia University. As a physician scientist, Dr. Newman conducts studies to investigate why some people with poorly controlled diabetes develop heart disease and others don't, or why some patients with blocked arteries have heart attacks and others don't. Dr. Newman is a national expert on the link between environmental exposures and how these exposures contribute to cardiometabolic disease, such as diabetes and cardiovascular disease. He has been awarded about $2 million, more than $2 million, in prestigious National Institute of Health and American Heart Association research grants, and has published more than 50 peer-reviewed medical journal articles. Dr. Newman is a colleague and a friend, and he is a fellow member of our Prevention Center. He's a great asset, and he is, as you will find out, a wonderful speaker. We're thrilled to have him speak today on this important topic. Diabetes, we all know, is one of the most important risk factors for cardiovascular disease. And unlike some other non-modifiable risk factors, diabetes is truly preventable and modifiable, especially type 2 diabetes. Jonathan, my friend, it's a great pleasure to have you on. And I'll hand the quote microphone over to you.
Thanks, Dennis. It's a pleasure to be here and to participate in this really excellent lecture series and symposia. And really credit to you and to Anya for keeping such an important program going. So thank you. It's a pleasure to be back. Next slide. I guess you can skip to the second one after that. Okay, so what I'd like to do over the course of about the next 45 minutes is to run through the following objectives and goals. We'll talk briefly about definitions of diabetes, which for the case, the situations that we'll get into today, the vast majority of what we'll focus on will be driven by type 2 diabetes. So, greater than 95, 98, 99% of the new cases of diabetes that we will talk about. Partially because type 1 diabetes, or failure of the body in a sense to produce insulin, the links between type 1 diabetes and heart disease remain poorly understood. We'll talk a little bit about primary versus secondary prevention and go through definitions of prevalence and burdens of diabetes, prevention of diabetes, some links between diabetes and heart disease, and some new advances. Next slide, please. Okay, so first, just sort of definition, kind of operationally, what is diabetes? Diabetes, as audience members probably know, is a condition where your levels of blood sugar or glucose in your blood become very high. And it develops when either your body stops responding to insulin, or it does not produce enough or any insulin. And there's really four main types of diabetes, which are shown here. Interestingly, prediabetes is getting included in these categories, but gestational diabetes, or diabetes related to metabolism and glucose handling for women that are pregnant. Type 1 diabetes, or kind of failure, the pancreas stops making insulin, or type 2 diabetes, which is the most common by far, where we become insensitive to, their tissues do not respond appropriately to the amount of insulin made by the body. So what happens in those circumstances is that diabetes, glucose builds up in the blood, spills out into the urine, and leaves the body. And that leads to the body losing its main source of fuel as glucose, even though there's still large amounts of glucose circling around in the body. Next slide, please. So what's important, the reason why we talk a lot about diabetes, and this is a little bit of a complicated figure, but the purpose of showing you this is that, 5 to 10 years before someone is diagnosed with diabetes, there are a complex series of metabolic changes that start to happen in the body with regards to the development of something called insulin resistance and higher levels of insulin, leading to changes in the way your body handles glucose even before you're diagnosed with diabetes. And then the two complications that we focus most on as cardiologists and cardiovascular scientists are related to microvascular, or changes to the small blood vessels, let's say in the eye or the kidney, and then larger blood vessels, or macrovascular complications related to, let's say, the arteries of the heart or the arteries of the leg. Next slide, please. So what has happened, and this is probably known to most people, is that the burden of diabetes and the prevalence of diabetes in the United States has really continued to grow, unfortunately, over the last 60 years or so. And these data were last updated in 2018. There is a more recent update. And unfortunately, more of the US is red than not red, showing that we are over 10% of the US population with diagnosed diabetes. The number with diabetes is actually probably much higher than that, because there's a large proportion of people that are undiagnosed, nearing over 30 to 40 million, if not higher, of the US population with diagnosed diabetes. Next slide, please. Now, one of the things that we know just by the numbers, and these are data from the American Heart Association, that one of the major causes of death for patients and of disability for patients with diabetes is heart disease. That the risk of heart and vascular disease for patients with diabetes is 2 to 3 times as great as that for patients without diabetes. There are nearly 300,000 heart attacks every year driven by diabetes and underlying metabolic problems leading to atherosclerosis and heart attacks. And patients with diabetes have, a upwards of 50 to 60% chance of dying from heart disease compared to someone without diabetes. So it really remains a large burden for our patients, for people with diabetes. And it's one of the main reasons we focus on diabetes as a main sort of group when we talk about heart disease and thinking about prevention. Next slide, please. So one of the things we looked at a few years ago is to look at, outpatient visits. And I'm going to present some data, but just kind of in a big picture way so that we can think about things constructively together. In the outpatient visit, when you see a physician in the office or another medical care provider, one of the things that needs to happen for people with diabetes is to think about the uses of things like statins to lower your cholesterol, in particular your bad cholesterol or low density lipoprotein cholesterol, the use of medications that lower your blood pressure called ACE inhibitors or ARBs. Those have, salutary effects on blood pressure and on the function of your kidneys, and potentially the use of antiplatelet agents, which like aspirin, which there's been a lot of things about aspirin in the news that we'll touch on a little bit. And unfortunately, these are medications that almost everyone or a lot of people over, let's say, age 50 with diabetes and high blood pressure should be on. And we looked at that for over about 14,000 people representing, over 40 million outpatient visits. Less than half of people in the outpatient clinic were getting these medicines, even though there's clear evidence to use them for primary prevention. Next slide, please. Equally alarming, if not more so, is lack of counseling for lifestyle, right? So we don't do a very good job of getting people the medicines that they need for prevention. And we do an equally, if not worse job about counseling, providing appropriate counseling for diet and exercise, lifestyle and weight loss, and smoking cessation. So there remains a big gap in sort of addressing risk for this large and growing population of the US population with diabetes. Next slide, please. So one of the things we looked at is sort of the main domains of what happens, primary prevention, just to make sure we're all on the same page. Primary prevention is to reduce the chance of ever having a problem with heart disease or having a heart attack, or heaven forbid, a heart attack or a stroke or peripheral artery disease. So you prevent the development of disease. In contrast, secondary prevention is preventing progression of disease once you have it, or recurrence of disease events like heart attacks or strokes once you may experience them. And it's a little bit different in terms of what we think about and the aggressiveness of the approach that we take to meet certain targets. But in either case, one of the things we looked at is the sort of reduction in risk that you could achieve with using some of the well-known strategies, like using aspirin or using medication to lower your cholesterol, aggressively lowering your blood pressure, having a heart-healthy diet, using diet and lifestyle together. You can see there's really a large magnitude in a reduction in cardiovascular disease events like heart attacks or strokes with the use of these kind of well-known and well-studied strategies for prevention. Next slide, please. So one of the things to show very quickly here is that, there's been a lot of data about using aspirin to prevent heart disease. And we'll touch a little bit upon the data that came out last month from the United States Preventive Task Force in terms of changing some of the guidance about using aspirin for primary prevention. The upshot about all of these data is to suggest that depending on your risk, and we're talking about primary prevention, so you've never had a heart attack, you've never had a stent, you've never had a procedure like bypass surgery or bypass surgery for your legs, The benefit of aspirin use overall is about the same as the increase in risk with bleeding. So it's really a scales of balance between a reduction in risk in, let's say, preventing heart disease and a risk of increase in bleeding. Next slide. And this was data that the US Preventive Task Force recently reviewed and found is consistent overall for people with and without diabetes, that our risk, let's say you see here in the major cardiovascular disease events of all the studies in over 134,000 people, there's about a 10% reduction in risk of having one of these events, of having an MI, a heart attack, a stroke, a type of an ischemic stroke. There was a lot of question about the risk reduction in colon cancer. And you see here the increase in bleeding. So it's really a benefit, a risk benefit in terms of primary prevention and use of aspirin for people with and without diabetes. Next slide, please. In contrast, almost everyone with diabetes who's over the age of 40 should be on a statin, a medicine to lower your cholesterol, because there is good evidence in over 15,000 patients followed for a long time, for more than 4 years, that taking a statin lowers your risk of having a heart attack or a stroke. The benefit is very clear in this regard. If you have diabetes and you have many risk factors, let's say you have diabetes and you smoke, or you have high blood pressure and you also have problems with your kidneys, you should probably be on a more potent form of a statin to help reduce your risk of ever having heart trouble. So the take home here, though, is that almost everyone with diabetes over age 40 should be taking a statin, a medicine to lower your cholesterol, to reduce your risk of having a heart attack or a stroke. Now, there is a lot of misinformation. We live in the age of misinformation about the benefits or harms, predominantly of harms related to statins, with regards to diabetes or dementia or muscle pain. And I can tell you that the incidence of those symptoms or side effects is rare relative to the benefit that you derive from statins. So there are people who have lots of symptoms with anything that they take, and sometimes that gets unfortunately attributed to beneficial medicines, statins being one of them. Next slide, please. So another thing we need to be very aware of is to make sure that your blood pressure is controlled if you have type 2 diabetes, or T2D is the abbreviation here. We know that high blood pressure or hypertension is present in more than 80% of people with diabetes, and that there's a synergy that diabetes and high blood pressure increase the risk for cardiovascular disease, for heart disease. But there's really been a debate that, well, how low should we treat your blood pressure? How low should we really strive for a goal? And right now, I would say that if you have if you have diabetes and high blood pressure, a reasonable goal to shoot for is a blood pressure less than 130 millimeters of mercury systolic. Some patients may benefit from a lower blood pressure, particularly if you are at very high risk, or you've already had a heart attack or stroke. It appears that there's an even greater benefit if you are at even greater risk. Next slide, please. So just to circle back here, so we've kind of quickly reviewed a lot of the evidence for primary prevention with use of aspirin, with use of statins, with lowering your blood pressure. But look at the blue bars in terms of the roles of nutrition, lifestyle, or lifestyle and medical therapy to reduce your risk of heart disease in diabetes. Next slide. So one of the things we know is that diabetes is preventable. And there was a beautiful study that was published now nearly 20 years ago, funded by the National Institute of Health, where they took over 3,000 people who had pre-diabetes. So they were kind of on the path to diabetes. They had abnormal, their blood sugar would get very high after they ate. They were overweight to obese. They had a very large waist circumference. And they were randomized in a randomized trial to one of three strategies, which you see here. Placebo, so a sugar pill, unfortunate, but not a sugar pill that would worsen your diabetes. Metformin, so a medicine that we've known about for over 40 years that reduces your risk of vascular problems in diabetes and can reduce your chances of developing diabetes. Or participants were assigned to a lifestyle intervention with metformin. And what you can see here is and they followed people over time for a median of nearly 4 years. And what they found is that there was a 30% reduction in developing diabetes with the use of metformin alone, and a nearly 60% if you really targeted lifestyle and used metformin to prevent diabetes. So diabetes is preventable. Lifestyle plays the major role, and a medicine like metformin may help you prevent diabetes even more than lifestyle alone. Next slide, please. Now, this is a very famous study where these investigators in Denmark took only about 160 people with diabetes, and they said, well, we're going to see if we really follow you very closely, and we send you to clinic where we really work hard on controlling your blood pressure, your cholesterol, your weight. We get you to exercise, stop smoking, versus having you follow up with your regular care providers for routine care of your diabetes. Patients who received the intensive therapy, the intensive lifestyle therapies, had a marked decrease in developing heart disease or complications related to diabetes. So we know when you target multiple risk factors, multiple lifestyle risk factors, you can really alter the trajectory of a condition like diabetes and its effect on your life. But it takes a lot of work, and you have to continue to do it. It's something that needs active intervention and active follow-up. Next slide, please. So the National Institute of Health really wanted to know, could you really prevent cardiovascular problems, cardiovascular events for people that were overweight and obese, compared to with a really intensive lifestyle intervention in a larger trial, right? One of the things in medicine, and we've all become, expert armchair epidemiologists in the time of COVID, but one of the key things about medicine and about science is reproducibility, is finding something and being able to have that finding reproduced in the hands of multiple investigative groups to approach what we think is truth. So the NIH ran a large trial in over 5,000 patients, randomized to an intensive intervention of diabetes support and education versus usual care. And what they found is the trial was stopped early because they did not see a benefit over about a median of 3.5 to 4 years of follow-up. And this was a real surprise to a lot of people. There was a real expectation that this trial would have shown a benefit, that based on the earlier results that we had, and anecdotal experiences that you could reduce the burden of heart disease with a really intensive lifestyle intervention. So why was this? Next slide, please. So the reason in part was that a lot of lower risk people were studied. And I won't get into the full details here, but basically the investigators set a very high bar, or rather they included patients at very low risk in this study. And that by using a composite endpoint, a combination of different clinical features, they made it really harder to detect a benefit with intensive lifestyle therapy. One of the key findings, I think, when you look back overall at this trial, is that if you have diabetes and you can lose weight, however you do it, with an intensive lifestyle intervention, with medicines we've seen recently, that portends a good future. It augurs a good outcome. And that was one thing that was seen very clearly in Look Ahead, was that those participants that lost weight did better over the long term with diabetes than those that did not in either arm of the trial. Next slide, please. So one of the things that has been talked about a lot is that diabetes is a risk equivalent, that your risk of having heart disease and diabetes is similar to someone who may have already had a heart attack or a stroke. But that may not really be the case. And when you look more closely, this is showing you the combinations of risk factors. So on the left side, you see no previous CHD. I apologize for the abbreviation. CHD stands for coronary heart disease. And this is showing that if you have diabetes with risk factors, your risk increases. And it's really not until you have diabetes and multiple risk factors, high blood pressure, high cholesterol, problems with your kidneys, that your risk becomes similar to someone who's already had coronary heart disease, who's already been told that they had a blocked coronary artery or had a heart attack or needed a stent or had bypass surgery. So there's a gradient of risk, that not all diabetes is the same, and it matters the company that you keep in diabetes with regards to your risk over time for having new heart disease problems. Next slide, please. So we also found that the same thing was true as we age with the development of problems of the disease in the arteries of your legs. And that if you had heart disease in the arteries of your heart, or CHD, and diabetes, as you got older, nearly a third of people in their 80s also had disease in the arteries of their legs. Interestingly, for people with and without heart disease or diabetes, the risk was similar for having disease in the arteries of your legs, and lowest if you had neither coronary heart disease nor diabetes over time for the development of disease in the arteries of your legs. So the point of this here is to show that diabetes and heart disease or vascular disease is a systemic problem. You have, lots and lots of meters of arteries in your body. And if you have a problem in one area, it's likely that you have problems in others. And hence, it's very important to treat those problems with strategies like lifestyle, diet, and medicines that act systemically, that act over your whole system, not over one tiny area where you may have a problem at that point in time and address acutely. It's the long-term system-wide management which will make the bigger difference over the long term. Next slide, please. So I want to show you this slide, not because I expect anyone to memorize it or think about it, but just to show you the amount of development in clinical trials that has happened over the last 15 years. And really, we've been part of a real revolution in terms of thinking about how we treat people with diabetes with newer drug classes that you may be familiar with, called the SGLT2 inhibitors, the sodium glucose-like transporter type 2 inhibitors. I'll spare you the tongue twister, or the glucagon-like peptide receptor agonists, to lower your risk of vascular disease for people with diabetes. And this was a big deal. This has been really a sea change in how we think about care for patients with abnormal glucose metabolism across the spectrum of risk. Next slide, please. So one of the things that I wanted to point out is that a lot of these data, and this is a little bit confusing to show in isolation, so I apologize, but a lot of these data, as I was sort of alluding to before, remember the difference between primary and secondary prevention. Remember, primary prevention is focusing on preventing the development of heart disease or vascular disease overall, right? And secondary prevention is preventing any problems once you've established vascular disease, once you've had a heart attack, you've had a stroke, you've had a blockage in the arteries of your leg. And what's interesting is that the data look better for use of the SGLT2 inhibitors, medicines like Jardiance, let's say, for prevention for people that already have heart disease established than they do for preventing people from developing heart disease to begin with. Next slide, please. We summarized a number of these studies about a year ago now, and showing overall the patterns that we see based on participants in these trials. Remember, as I said, that clinical trials and repetition in clinical trials is really key for us to establish an evidence base for what we know works for the practice of medicine and the care of our patients. And there's a very consistent signal depending on the trial, across these trials, based on the risk profiles of your patients, that SGLT2 inhibitors are really good for some things, particularly for reducing your risk of heart failure, which is not the focus of today's talk, but does show you that there's other things that we have to think about when we take care of people for diabetes. Next slide, please. The other thing that has been really interesting, and again, a very busy slide, but just to update you quickly, is that we have seen a nice benefit in protecting the kidneys for use with the use of SGLT2 inhibitors. As you probably know, renal impairment or impaired kidney function is one of the biggest problems for people with diabetes. And diabetes is the primary reason that people end up on needing dialysis or have impairment in their kidney function over time. And interestingly, one of these medicines, the SGLT2 inhibitors in particular, really seem to benefit your kidney function when you have diabetes, with or without known heart disease, which is really an important sort of addition to our treatment and care for people with diabetes. Next slide, please. So one of the things I think we're really thinking about as sort of the next steps in care for our patients with diabetes is thinking about really the big population of people, the bottom of the pyramid here, where people may have diabetes, and we're focusing on prevention, right? Primary prevention, where medicines like the SGLT2 inhibitors may prevent even the first occurrence of things like heart failure and kidney disease, but may be different in terms of preventing a heart attack or a stroke. In contrast, these medicines may have added benefit for secondary prevention once you've already had a heart attack or stroke, and reduce, let's say, what are called major adverse cardiovascular events, in addition to hospitalization for heart failure and protecting the kidneys once you've had an occurrence of something to begin with. Next slide, please. So I would be remiss if I didn't touch upon diabetes and COVID in the age of COVID. We know that patients with diabetes are more likely to have serious complications from COVID-19. Sorry, I wrote COVID-10. I don't really know where that came from. That's a typo, but it looks like COVID-19 may exacerbate some of the metabolic changes that we see in diabetes and some of the severe metabolic changes that can occur, things like diabetic ketoacidosis, where the balance of acid and base in your blood, in your body gets really out of whack, and other situations related to that, such as other severe high glucose states or severe states of being really resistant to insulin. As with many things, the severity of diabetes, if and when you let's say are affected with COVID, likely matters for the outcome. So the longer you've had it, the more poorly controlled your diabetes, and the interaction between diabetes and other heart disease risk factors like high blood pressure, kidney disease. One of the important things that we've seen with diabetes and COVID-19 has been the risk of medicines to control your blood sugar when you're acutely ill for COVID. And some of these medicines, like the SGLT2 inhibitors, may actually be beneficial and reduce your risk of hospitalization or complications related to COVID-19 or infections with SARS-CoV-2, but we don't really know. The data is a little bit unclear as of yet. Importantly, the benefits of vaccination appear as great, if not greater, for patients with diabetes compared to those without, likely based upon the underlying risk that people with diabetes may have for more severe complications secondary to COVID infection. Next slide, please. So just to sum up briefly, what I wanted to do today is to sort of touch upon briefly primary and secondary prevention of heart disease for patients with diabetes, to give you the kind of overview that the epidemic of type 2 diabetes is really a lifestyle epidemic, which is largely preventable and can be improved by diet and exercise and weight loss. There is a very clear role for medical therapies to reduce your risk of heart disease for patients with diabetes, namely making sure that your blood pressure is well controlled, making sure that you're taking a medicine to lower your cholesterol. And for certain people, depending on your age and risk factors, an aspirin may be useful, but it's very important for you to discuss this with your doctor, even though aspirin is over the counter and is overwhelmingly a safe medicine. It's still very important to have a risk-benefit discussion, given that some people may have trouble related to bleeding on things like aspirin. The cornerstone of all of this, of prevention, both for people with and without diabetes, is lifestyle, right? Of how we take care of ourselves, the diet we eat, our physical activity, just walking, climbing stairs, and physical exercise, physical activity and exercise is really the cornerstone for prevention. That we can use all the fancy medicines in the world or fancy interventions, but if there is a lack of attention to lifestyle, it's often for naught. So I can't emphasize that last bullet enough. And I really wanted to close on that because I think that's probably the most important element for people with diabetes, is really to focus on prevention, and lifestyle is the mainstay of prevention. Next slide, please. So thank you very much to Dr. Goodman, to Anya for this wonderful symposium, and we have some time for a few questions.
Okay, Jonathan, that was great. Really a tough topic to cover so much, and you really hit all the bullet points. So I'm very grateful. That was fantastic. I got a lot of questions. I'm going to throw at you sort of a combination of questions.
Sure.
Questions about aspirin, which you've clearly said it's a risk-benefit ratio.
Yeah.
But can you help people a little bit? So if you've got diabetes, but you've got multiple risk factors and no history of GI problems, are you more likely to use the aspirin? And would you ever use a calcium scan to help you, where we're actually saying, look, you've already got evidence of atherosclerosis? And the last question on the aspirin story is there a risk of a bleeding? People are worried about a stroke, because that clearly puts the risk much higher. And therefore, if you've got someone who's got severe hypertension, that factors in if you're going to start aspirin. So I don't know if you can do a little deeper dive and help a little bit. Of course, you're going to speak to your doctor, but how do you approach it?
Right. So the first part of that great question and points regarding the use of coronary calcium scans and let's say use of guiding aspirin therapy. So if you have diabetes and multiple risk factors, or you have known atherosclerosis on a coronary calcium scan or other imaging modalities of the arteries of your heart, you likely derive greater benefit than harm from use of aspirin, right? It's all really about that risk-benefit ratio. So a coronary calcium scan is increasingly available and can give you important information that can guide the use of risk factor, the use of medicines to lower your risk, whether it's intensifying your use of statin therapy or staying on an aspirin. But I think the change in the statement from the US Preventive Task Force was in line with larger randomized trials that showed that for most people, particularly as we get older, there is a clear risk with aspirin. And as you pointed out, the risk of stroke, including, a bleeding stroke or a hemorrhagic stroke, goes up with aspirin. And that can be a real catastrophic or a really terrible event. Thankfully, it is extremely rare. And you brought up the question of that happening in someone with a very high blood pressure, which I think is a very good point, if only to emphasize that controlling your blood pressure is one of the most important things that people with diabetes should focus on. So I think you've illustrated that it's there are sort of multiple dimensions of prevention. And certainly for the case of something like aspirin, and I want to reiterate this, that we are not talking about stopping aspirin if you've had a stroke or you've had a heart attack or you've gotten a stent or you've had bypass surgery. You should remain on aspirin. This is not a question for you to call your doctor and say, I heard I should stop my aspirin because there was something in the news about it. This is saying for people who've never been told that they have coronary atherosclerosis or have never had a heart attack nor a stroke, they should not start taking aspirin for prevention in the absence of other things that increase their risk. And that, I think, is really the key element here, because there can be harms associated with it, especially when you look over hundreds of thousands of people.
Yeah, that's clearly the right approach, in my opinion. I think we should also mention age. The older you are, the more likely to have a risk of bleeding. And that's a group that you really have to be careful. So the bottom line is you definitely want to discuss it with your physician. Don't just start taking baby aspirin without doing that. I've got a question about metformin. Can it affect your blood pressure or cholesterol? I'm not aware of that, but maybe you know some data, because
that's a good question. I don't know. I have not heard of metformin affecting your blood pressure. Metformin, I think, can have beneficial effects on your cholesterol, in part due to weight loss.
Right.
So, metformin, we have lots of many years of good real world evidence with the use of metformin, both for preventing diabetes and helping with weight loss, and in the real world setting of prevention of vascular problems. So metformin is a a mainstay therapy for those reasons, and because it's it's very inexpensive. And it is something kind of the background therapy that many people take. Now, whether eventually we'll get to a point where some of the newer agents may replace metformin, I don't know. That hasn't really been evaluated, but metformin, I don't know of it affecting either blood pressure or adversely affecting your cholesterol.
I mean, I think in terms of side effects, a lot of GI stuff, bloating, abdominal discomfort, and those are nuisance side effects. Again, something to be discussed, but not any major effect on blood pressure or cholesterol on its own. A question about what is a moderate intensity statin? What do you mean by that? Has it got anything to do with the dose and how often you should take it?
Yes, sorry, thank you. That part of the slides here were used for other talks to doctors treating patients. So I apologize for not clarifying that. So in general, a moderate intensity statin is a dose of one of the statins, the generic names for which are things like simvastatin, atorvastatin, rosuvastatin, in not maximal doses. So generally for something like atorvastatin, a moderate intensity dose would be a dose of 10 to 20 milligrams, and a dose of 40 to 80 milligrams would be considered a high intensity dose. For something like rosuvastatin, 5 to 10 milligrams would be a moderate intensity dose, and higher than that, 20 to 40 would be the high intensity dosage. So it really refers to the dose and the type of the statin. And rosuvastatin and atorvastatin are the most potent lipid lowering statins that we have, classes of those medicines that we have, and have the greatest reductions in cholesterol through those pathways.
And there are times where we use a high intensity statin, after an acute coronary syndrome or something like that, because they have a more potent effect and you really want to get the LDL as low as possible. I want to give a shout out to Stephen Ho, who really does a great job of asking a lot of very, very good questions. Here's another one of his questions. There's recent media hype that apparently type 2 diabetes can be reversed. Is there really such a thing as reversal of diabetes, or once you've been diagnosed with it, do you have that diagnosis forever?
That's a great question. So I have a couple of thoughts on that. You have to remember that we in medicine like to operationalize things with cut points, right? So we say that if your measure of blood sugar, blood sugar changing something in your blood equates to a diagnosis of diabetes when it's over this percent, right? Your body doesn't care. In this case, it's a hemoglobin A1C over 6.5%, right? Your body doesn't really care if that's 6.4. Your body doesn't know any different if it's 6.4 or 6.7. We operationalize things for cut points. Now, the important thing is, can diabetes be cured? Type 2 diabetes be cured with lifestyle alone? Now, the short answer would be that we've shown that you can prevent it, right? That if you have prediabetes, you can do lots of things to prevent the development of diabetes. And if your blood sugar is abnormal to the point, let's say you've gained a lot of weight and you've been inactive and you haven't been taking good care of yourself, and your blood sugar, you meet then diagnostic criteria for diabetes, and you start to take really excellent care of yourself, can diabetes regress? Yes, definitely. Type 2 diabetes, you can lose enough weight, your blood sugar can normalize, and you can be effectively kind of cured for diabetes, but we know that the risk of it coming back, of recurring, is greater for someone in that circumstance than, let's say, for someone who's never developed diabetes. So it's a really interesting question, but it's a little bit nuanced, because a lot of these things, like blood pressure, it exists in a spectrum, right? We measure your blood pressure at one point in time, but your blood pressure is fluctuating at multiple points in time throughout the day and throughout your life. So similarly with something like diabetes, this is different for something like type 1 diabetes, right? Type 1 diabetes, your body fails to produce, stops making insulin, right? That is not something you can cure with lifestyle. That's never been shown. You need insulin you need to receive insulin because your body doesn't make it. It's a failure of your pancreas. That's different than what happens in type 2 diabetes. And type 2 diabetes can get so advanced that you need insulin because your body can't make enough, right? Eventually it will happen. But for a lot of people, it can effectively be cured or treated with lifestyle alone. This is type 2 diabetes. So it's a really interesting question.
I just wanted to throw in a comment. I think one of the saddest things for me is that billions of dollars are spent on medications to treat diabetes. We've just got to remember that prevention is the absolute key. Right, and it's sad that we don't spend more money. We try really hard. And as you know, in our clinic, we've got a nutritionist. And it's hard to get people to comply and understand that you really can prevent secondary diabetes if you work hard at it. And I know that's something that you're pushing for all the time. So yeah. on that note, there's a question about, is there a specific dietary approach to someone with diabetes? Now, we're not talking about the weight, which you want to lose weight. We understand that. But we talk low glycemic foods. But what about red meat, calorie restriction, intermittent fasting? Right. Is there any data that anything more than just losing weight and low glycemic index foods can help you?
That's also a really good question. The short answer is that I have not seen evidence that is reproducible in multiple studies outside of what Dr. Goodman has just mentioned. So in general, the kind of big principal things that we know are beneficial for a heart healthy diet. So complex grains, lower amounts of protein sources derived from animal sources of protein, low amounts of saturated fats, higher amounts of polyunsaturated fats. Now, there has been a big shift in recognizing and, let's say, using higher sources of protein versus higher sources of carbohydrate diets. And part of the benefit there, I think, overall, big picture, and I'm not a nutrition scientist, is that there's a lower calorie count and a lower glycemic index, or sort of sugar to fat ratio that exists for some of the protein-based diets. And those diets, I think, can help you lose weight, which ultimately weight control and normalizing weight and calorie restriction leads to the largest reduction. So I think that those are strategies to get you to that goal. I don't think that there's a silver bullet, whether it's the South Beach diet or the Atkins diet, that will get you there. There are different ways to skin a cat, so to speak, of reducing your caloric intake to control your body weight, to control your blood sugar. And there are multiple strategies to approach to get there. Right. I think that's kind of the take home.
I think we should just remember that processed foods are full of fructose corn syrup. And that's one of the biggest problems. People like the donuts and all that kind of thing that you eat just with a cup of coffee. You're really doing yourself harm when it comes to diabetes big time, because it's not only calories, but it's sugar.
That's right.
And that's poison. I'll take this last question, Jonathan. Are there natural supplements as effective as metformin in preventing diabetes? And, it all depends on who you ask. And I am an integrative holistic cardiologist, and I feel that I've got a good feel for both sides. The answer is we don't have any trials with one versus the other. There are a lot of people that I see sometimes they don't want metformin. And there are some products like Bergamet and another one called Berberine. There's a product called Curulin. These are not instead of metformin. You have to have a conversation with your doctor. Metformin's got other benefits, but they are something to talk about. And I do discuss that with some patients who want to give it a try. The bottom line is you've got to lose weight. You've got to have lifestyle changes in conjunction with whatever you take. And whenever I do let someone try one of these supplements, I always give them a 3-month trial, because in the end, we've got to see some results. We want to know what your fasting blood sugar is. We want to know what your hemoglobin A1C is doing, because we can get answers very quickly from just looking at your blood work. Jonathan, Dr. Newman, that was superb.
Thanks,
this
Tom.
is not an easy talk to give. There's so much information. You kept it simple and you gave us a ton of great information. So thank you very much. And I'm gonna end it there. Ania, thank you as always. We can't do this without you, and we're all very grateful. So we'll look forward to seeing you all. I told you about our programs that are coming up. Please tell your friends, give us some feedback. One of my questions is this 5 o'clock slot a good slot for you? If you prefer to make it at 6 o'clock, let us know. And if there are any topics you'd like me to cover, I'm happy to do that. So signing off, and thank you again.